then, Sudarshan?
Ma'am, give me 1 minute, ma'am.
Sure. Yeah.
Yeah, it's
Ma'am, Anjali ma'am, I'm starting the session, ma'am.
Yeah, sure.
Good evening, everyone. I welcome you all at another webinar of ICRI teaching program. I request the organizers to start the session. Over to Dr. Anjali ma'am.
Thank you, Sudarshan and team Vidocto. And I want to thank the ICRI team, Dr. Sikandar, for giving us the opportunity to hold the emergency radiology module, which is an integral part of radiology practice. These are the cases which we cannot afford to miss in the emergency room or in the middle of the night or in critical care units. And today is our second session of the emergency radiology module. I have the first speaker here, Dr. Smita Manchanda, and I would like to introduce Dr. Smita Manchanda, who is an additional professor in the Department of Radiology at AIIMS, New Delhi. Her areas of interest are women's imaging and head and neck imaging. She has published extensively, delivered almost 100 guest lectures, has co-edited radiology textbooks, and also authored the ICRI guidelines on women's imaging. She's also the recipient of the President's Appreciation Award by the Delhi State Chapter of the IRIA. And Dr. Smita would be showing us interesting cases of gynecological emergencies. Over to you, Dr. Smita.
Thank you, ma'am. Thank you for the kind introduction. And I would like to thank Team ICRI, IRIA for giving me this opportunity. So I'll just share my screen. Okay, so basically I'll be covering imaging of gynecological emergencies today. So this is how I've organized my content, primarily as the clinical presentation. What is the classification? What are the common etiologies, whether they are related to the uterus or the adnexa, certain case scenarios, which we will try and make interactive, and then the conclusion. So the clinical presentation, as all of us know, would either be an acute pelvic pain or it would be bleeding per vaginum. So the acute pelvic pain can have other non-gynecological causes, which can be gastrointestinal or urological. So I will not be covering that, and ma'am would be covering the urological emergencies. But I would be restricting myself to those etiologies which are gynecological in origin. The baseline imaging modality, as all of us know, would be an ultrasound, whether it is a transabdominal or a TVS or a truss. CT is often used in the emergency settings, especially when the localization is difficult on the basis of symptoms alone. MR is problem solving in indeterminate ultrasound or CT findings. So if we go into in terms of the classification, so there can be disorders of the uterus and the cervix, or there can be disorders of the adnexa. So in terms of disorders of the uterus, so patient can be presenting with acute uterine bleeding, where the common causes being RPOCs or AVM or the GTNs. They can be acute leiomyoma or fibroid complications like torsion of the leiomyoma. They can be a torsion of the uterus. They can be a uterine perforation. They can be hematometrocolpos, which can present in, especially in the younger pediatric age group and adolescent patients, where it can present as acute pain or acute urinary retention. And they can be an inversion of the uterus, which commonly occurs if there is a prolapsing leiomyoma. In terms of disorders of the adnexa, there can be acute hemorrhagic lesions, where there can be a rupture of the corpus luteum or the endometriotic cyst. They can be ovarian torsion, or they can be a torsion related to a pre-existing cyst or tumor, or there can be a rupture of that tumor. PID is a very common presentation in the acute setting, especially with acute pelvic pain and ovarian hyperstimulation syndrome. So these are predominantly gynecological causes. I have not included the obstetric causes because that is a separate talk by itself. So what is the approach that we should follow when we are, because see, whenever the patient presents with either an acute pelvic pain or bleeding, we are trying to in our mind, we try to identify whether the cause is uterine. If we have excluded the gastrointestinal and the urological causes, so we would think that either there is some abnormality associated with the uterus or with the adnexa. So let's see in terms of uterine abnormality. So it can be an endometrial abnormality where there can be fluid or collection within the vagina or the cervix. There can be a hematometrocolpos, or there can be a myometrial pathology where there can be a uterine AVM, or there can be the leiomyomas, which can, if they are subserosal in location, they can lead to torsion of the leiomyoma. In terms of the endometrial mass with a distended canal, there can be a submucosal leiomyoma prolapse, which can also lead to the inversion of the uterus. So let's see in terms of case scenarios. There's a 12-year-old girl who's presenting with acute persistent pain abdomen since 10 days, and now she has an acute urinary retention since 1 day. So here we have the MR images. So you can see that this is the T2 sagittal image where this is the bladder and this is the vagina, which is distended with intermediate signal contents. There is a complete obstruction in the level of the distal vagina. This is the rectum. And here you can see that there is some degree of a hematometra as well. Now, these are the T1 and the T1 fat sat images. So in terms of MR, a T1 fat sat image is very crucial in pelvic imaging for gynecological etiology. So we can identify that, yes, there is blood. So the cause is a hematocolpos due to the lower vaginal atresia. Now, in terms of a patient who's presenting with primary amenorrhea with a cyclical abdominal pain, palpable lump, and may present with an acute urinary retention, the cause can be either a transverse vaginal septum or imperforate hymen. So in terms of this, clinical examination can also help differentiate, because in terms of imperforate hymen, there is a transilluminant bulging vaginal membrane, whereas in terms of a transverse vaginal septum, there would be a thick and pink bulging vaginal membrane, and thin if it is a less than 1 centimeter septum, thick if it is more than 1 centimeters. A low septum is less than 3 centimeters, mid 3 to 6 centimeters, and high more than 6 centimeters distance from the introitus. And most common is the upper vaginal septum. So hematometrocolpos, as all of us know, is a Mullerian duct anomaly, and imperforate hymen, non-communicating uterine horn, vaginal septum, vaginal atresia can all lead to this entity. Acute pelvic pain because of the obstruction of the endometrial secretions, which cannot be secreted. So clinical presentation, classically an adolescent girl with primary amenorrhea, pelvic pain and distension, and the pressure effect and leading to acute urinary retention. So imaging, all of us know, echogenic contents on ultrasound, distended vagina or uterine cavity. They can be bilateral endometriotic cysts, and the other associated Mullerian or renal anomalies should be evaluated. Similarly, evaluation on the MR, the details of the uterine contour, cavity, cervix and vagina. Another case, a 17-year-old girl, she has an history of primary amenorrhea, cyclical abdominal pain, but she had undergone a cervicovaginoplasty and Malicot insertion at about 15 years of age. There was an incomplete expulsion of the Malicot catheter, according to her, 20 days back. And now she has this, again, pain recurring. Now, in local examination, there was no Malicot catheter, and per vaginum, there was a patent vagina because the cervicovaginoplasty had been done, and there was no Malicot catheter felt even on the clinical examination. So this is the ultrasound image. So here you can see that this is the bladder. This is the region of the reconstructed vagina. And what are we seeing? We are seeing the tip of the Malicots within the bladder. So here you can see it in the sagittal image. So this is the IUCD, and now we can see that it is penetrated through the vagina, and it is lying within the bladder. So these are the CT urography images, and here you can identify the bulb of the Malicot's catheter, and this is the 3D reconstructed image. So on cystoscopy, the Malicot catheter flower was seen protruding into the bladder lumen from the posterior wall in a supratrigonal location, and this was then retrieved through the cystoscopic approach. So this is the migration of a intrauterine device. So this was removed by the transurethral resection. Now another lady, 28-year-old, pelvic pain aggravated during micturition. So here we can see that there is a slight lateral deviation of the intrauterine contraceptive device, and this is the TVS image where we can see that it is perforating out through the myometrial margin. So this was a perforation by an intrauterine device. another CT image. So here we can see that this is the reconstructed image. So here there is a beyond the serosa, this margin is protruding. So perforation. So this is also classified according to different terminologies. I'll just brief that. So clinically, usually seen in about 25% of the patients, mostly they are asymptomatic, but they can present with severe abdominal pain and bleeding. So if it's a properly positioned IUCD, then the stem is straight and entirely within the endometrial cavity, arms extending laterally at the fundus. So placement should be fundal, and the distance from the top of the uterine cavity to the IUCD should be 3 millimeters or less. So it is a displaced IUCD, or it is embedded, or it is perforated. So displaced means that is displaced from its normal proper position in the fundus. Embedment means that it has penetrated into the endometrium or myometrium without extension through the serosa. So the serosal margin is still intact, but perforation is when it has perforated through all the 3 layers of the uterus and the IUCD is partially or completely within the peritoneal cavity. So on conventional radiographs, if there is a complete perforation, then the IUCD would be located above the pelvic brim, or far lateral on an AP view, or far anterior posterior on a lateral view. So these would be the suggestive sign that we need to pick up. On CT, as we have seen, that it can be seen partly within the uterus, or it may be totally lying free within the peritoneal cavity, and there may even be an intra-abdominal migration. Now there's a 31-year-old lady with heavy continuous bleeding since 15 days. So here, what are you seeing? Now, this is the T2 sagittal image. So this is the endometrial cavity. And now we are seeing a well-defined T2 hypointense, predominantly with some intermediate to bright areas, mass lesion within the lower part of the endometrial cavity. So this is the coronal image. So this is the cavity which is being distended by this mass, which is also protruding into the cervix. So this was a prolapse of the leiomyoma into the cervical canal. So prolapse is usually with the submucosal pedunculated leiomyoma. And then when it prolapses out, it can present with pain and abdominal vaginal bleeding. So the typical ultrasound appearance would be that it's like a fibroid. It's a well-defined hypoechoic mass. It will show posterior acoustic shadowing, but it can be seen as a submucosal lesion going from the endometrial cavity. And on MRD, classically, the submucosal component of the leiomyoma stalk and its uterine attachment with extension into the endocervical canal can be seen. And this broccoli sign is also been now described not just for leiomyomas, but also any lesion which is prolapsing, whether it is an adenomyoma, adenosarcoma, or even endometrial carcinomas, which are mass forming. Now, another patient, she's a 20-year-old lady. She's having excessive bleeding post DNC that is dilatation and curettage for abortion. And the beta HCG level is only 12 milli-international units per ml. So here, what are you seeing? This is a TVS image. Now we are seeing the endometrial cavity, and we are seeing a well-defined anechoic lesion, which is partly cystic and partly tubular in appearance within the cavity. On putting the color Doppler, so intense vascularity and the typical Indian type of pattern is seen. When the CT angiography was done, we could see that there was a hypertrophied left uterine artery and there was a rounded pseudoaneurysm, which was seen within the as this lesion. So this was a uterine pseudoaneurysm. Another lady, 39-year-old, complaining of menorrhagia. Now she also gave a vague history of amenorrhea. Beta HCG when it was done was 25 milli-international unit. So in what we are seeing is this is the endometrial cavity. So this is what we really need to identify on real-time imaging also, that whether the lesion is within the endometrial cavity or it is extending out into the myometrium. So that is the basic difference between a retained product of conception and the GTN. Because many a times, especially in our settings, when patients are coming from the rural areas, they might not know their last menstrual period, they are not sure about the period of amenorrhea, they would not have got a UPT test done. So the presentation can be that just presenting with excessive bleeding. So presence in the casualty, patient is bleeding excessively. So you might not get any help from the history related to her menstrual cycle. So that is the time that you need to identify, one, the beta HCG levels, and secondly, on the ultrasound or the MR, whether it's an entirely endometrial lesion or it's an endometrial plus myometrial or myometrial lesion. So here we can see that it is confined within the endometrial cavity and it has only got minimal flow. So this is suggestive of a mildly vascular RPOC correlating with the beta HCG levels. Now here you can see that 30-year-old lady, beta HCG was 49, done 24 hours later, it is only 51. So there was no doubling. And here you can see that this lesion is again echogenic, and this has got a intense vascularity to it. And here we can see that it is a low resistance kind of flow with an RI of 0.37. And this is the MR image. So here again, you can see that lesion has got numerous flow voids within, which represent a increased vascularity. So lesion confined within the endometrial cavity has intense vascularity, so highly vascular retained products of conception. Now another lady, 27-year-old, she had a recent history of MTP by pill, but now she's having menorrhagia. So the MTP was done as a only by medical management, and the beta HCG levels now done were 15,000 milli-international units. So now what do you see? Again, a well-defined echogenic mass, but this is the endometrial cavity, and we can clearly see that part of the lesion is going into the myometrium. So we also have intermediate flow within this lesion, mild to moderate. And here also we can see that this lesion is partly within the cavity and partly within the myometrium. So this should be the signal of the myometrium. Here we are seeing that this is this intermediate to hypointense mass lesion replacing the signal of the anterior myometrium. So this was a picture of an invasive mole. That is, the lesion has a beta HCG higher values, and there is endometrial and myometrial component with intermediate vascularity. So this is the key concept of gestational trophoblastic disease, arteriovenous malformations. See, AVMs can happen post-uterine instrumentation. So that is one of the commonest causes that we see, that the patient has undergone a dilatation and curettage for a abortion, whether spontaneous or medical termination, and this patient presents with a pseudoaneurysm or an AVM. But it can also happen secondary to the gestational trophoblastic neoplasia. Both the patients would present with bleeding per vaginum, and on ultrasound would be seen as multiple anechoic tortuous vascular channels showing high velocity, low resistance flow. On MR, multiple flow voids are seen with hypertrophied uterine arteries. Management is by uterine artery embolization. In retained products of conception, the persistence of placental tissue is there in the uterus following delivery or an abortion, and this may also show intense vascularity. So now what the terminology is actually used as the EMV, or the enhanced myometrial vascularity. In both the situations, uterine artery embolization will help, but it depends on whether the patient wants, because the post-UAE, there are some infertility issues. So the patient choice is also important, whether they actually want to undergo a UAE or not. But because in the highly vascular retained products of conception, many times they just follow the patient on medical management and they resolve by themselves. So the AVM can be one thing, that it is a part of the spectrum of the GTN, or it can be a primary AVM which has followed post-instrumentation. In terms of retained product of conception imaging, so what I had already discussed, that in the endometrial cavity with variable vascularity. So again, enhancing mass in the cavity, and same thing on the MR. Hypervascular RPOCs may cause massive bleeding similar to uterine AVMs and may require UAE prior to the intervention. So here you can see this is within the endometrial cavity, but see how much of vascularity it is having. And here also you can see lesion is confined within the endometrial cavity. We can see that entire intact junctional zone, but see the degree of flow voids within this lesion and the intense vascularity within the myometrium as well. So this was hypervascular RPOCs in a 27-year-old lady with pervaginal bleeding post-MTP for 1.5 months. So this was the uterine entry embolization which was done in this lady. So here we can see a selective run of the left uterine artery, and then post-embolization this with the PVA particles. And on the right side also you can see the hypertrophied uterine arteries and the nidus, and this is the post-embolization run. So GTN versus RPOC, the basic presentation might be similar, that is irregular vaginal bleeding or excessive bleeding. The patient just presents in casualty with an excessive bout of bleeding. So in terms of GTN, because the beta HCG levels are very high, so the patient may have a hyperemesis gravidarum with excessive uterine size, or even may give the history of a transvaginal expulsion of the hydropic vesicles, may have toxemia. Beta HCG levels are very high. RPOCs, usually the beta HCG levels are lower. So again, the main difference, just always remember RPOC is endometrial epicenter. So the myometrial invasion is less, It's a relatively small mass. There would be no bilateral ovarian thecal lutein cyst or ascites. And it's a non-invasive endometrial mass with mild or no enhancement. Whereas in GTN, primarily a myometrial epicenter, myometrial invasion, large placental venous legs, large mass, and bilateral thecal lutein cysts may be seen. On MR, again, invasive myometrial mass with avid enhancement. So just to show you the differences, see epicenter endometrial, predominantly myometrial. Myometrial invasion not there in RPOC. Here we can see that this is within the cavity, and here again within the myometrium. Size of the mass, that is actually variable, but yes, generally smaller in the RPOCs compared to a GTN. Again, morphology, so GTN, typical snowstorm of the H mole you can see, or you can see echogenic mass of the RPOC. Endometrial thickness, so this stripe is normal and then this mass is in the cavity. Here, a smaller endometrial thickness because mass is predominantly myometrial. RPOC ovary is normal, GTN thecal lutein cysts may be seen, or multiple large follicles may be seen. Vascular indices, generally both will have a low resistance flow, not much difference. PSVs are higher in GTNs. RPOCs again within the endometrial cavity. So here you can see in the post contrast also, they are enhancing to some degree, but predominantly it is the blood clot and some enhancing products. Whereas this is the GTN. Here you can see the T2 hypointense, the case we saw earlier. And here we can see that it is intensely enhancing. The whole mass is enhancing. So GTD, again, a spectrum of benign and malignant. So H mole and choriocarcinoma spectrum varies. And the benign one being complete and partial H moles, and malignant being invasive mole, choriocarcinoma, PSTT, ETT. So this I'll just rush through. Complete H mole, everybody knows, typical appearance within the casualty, large ovaries, snowstorm appearance within the endometrial cavity. Patient can have hyperemesis or other signs of a very raised beta HCG level, no fetal parts. If you see fetal parts along with that, so some degree of a fetal formation or seen within some placental tissue, some formation of a liquor, and along with that the fetal pole, so then it is a partial mole. Post-molar GTN, so always remember that it is not really now the criteria after the 2021 update. The absolute values are not really taken into account. Those I'm just telling that mostly the values are like that, but the criteria for evaluation, the FIGO criteria, is only the measurements taken over a period of 3 weeks. So 4 measurements over a period of 3 weeks, days 1, 7, 14, and 21. So that either there's a plateau of the beta HCG or there is a rise in 3 consecutive weekly measurements. So most of the times, even if the patient is presenting in an acute setting with the bleeding, the patient is generally managed conservatively till the time the imaging is done and the beta HCG levels are measured over a period of 3 weeks, and then only a diagnosis. If you get metastasis, then straight away, yes, it is a choriocarcinoma. So along with the histologic diagnosis of choriocarcinoma. So this I've just made a table which is helpful. Don't take these absolute values. It's just that the in complete H mole, generally very high levels, even in partial mole and invasive mole. So these are in terms of the GTD, but in PSTT and ETT, there are relatively lower levels. So snowstorm appearance in complete mole, Swiss cheese pattern with fetal parts in the partial mole, invasive mass in myometrium, invasive mole with metastasis, then it is choriocarcinoma. And this is a very, very aggressive looking mass, which is intensely enhancing, and patients really present with excessive bleeding. So here again, chemotherapy, but with PSTT and ETT, it is very difficult to identify. Most of the times it's a post-op diagnosis. A histopath diagnosis. So here you can see again, predominantly, here you can see the cavity is separate, and this is within the myometrium. So this would be a highly vascular because of the intralesional arteriovenous shunt. So this is the appearance. Here you can see that excessive large mass which is distending the endometrial cavity. There are numerous arteriovenous shunting which is occurring within this lesion, and there are lung metastasis. So this was the case of a choriocarcinoma. Now here again, you can see that the sharply marginated lesion cavity is separate. It is predominantly myometrial. It is intensely enhancing, T2 intermediate to hyperintense. In terms of PSTT, these are taken from literature. So this has been described as either a hypervascular or hypovascular pattern. Again, it is biometric in location, mild enhancement, low levels of beta HCG, mostly diagnosed histopaths. Similarly for ETT, where it is said that if there is a well circumscribed mass with a sharp border and peripheral halo of low echogenicity, but usually no diagnosis is not really made in the pre-op setting. So what happens is that patient is coming to us with a postpartum or post-evacuation. She has undergone an MTP outside and she's presenting with bleeding. So the beta HCG levels, if there are low levels or higher levels, the patient has come for either an ultrasound or MR. So if we are seeing a non-invasive endometrial soft tissue, so depending on the vascularity, it can be an RPOC from grade 1 to 2 to 3. In grade 3, it may require a prior UAE followed by DN dilatation. If there are dilated vascular channels only identified, you do not see an echogenic mass, it can be just primarily an AVM or just a pseudoaneurysm if that's like a cyclic outpouching, and then the patient undergoes a uterine artery embolization. But if you're seeing an invading myometrial soft tissue, your higher levels of beta HCG, then it can be a spectrum of GTN, and then we evaluate further. So here you can see a 26-year-old lady, intermittent heavy bleeding, post-dilatation, curettage. Now what is happening? Almost the entire cervix, and you can see in the lower uterine body this anechoic space. And whenever you see this anechoic space, just put on your color box. Never think of it as a cyst. This has to be evaluated on the color flow. And you can see that it is an arteriovenous malformation. So this was the MR image. So T1 in bright areas and large flow voids, signal voids also on the T2 image. And this is the post-contrast image where we can see that intense filling in with the contrast acquired uterine AVM. So this was the uterine artery embolization which was done. So this is the selective run where we can see that there was this sac-like outpouching and then the filling of the veins, and this is post-embolization. So the AVMs can be seen congenitally acquired. When it's a congenital AVM, then the patient usually presents as a woman in childbearing age who's having recurrent or spontaneous abortion. So that is a totally different presentation. Does not really present in the emergency setting. But in acquired AVMs, patient will present with, sudden bouts of excessive bleeding, continuous or intermittent, and you usually get a history. So they can be the uterine surgery, or the patient has undergone dilatation, curettage, or some PID, GTN. So some associated history you will get. Caveat what I had told earlier, the arteriovenous shunting, a typical feature of AVMs, does not really imply the presence of an AVM. So when it is associated with an echogenic mass, think about a GTN or the enhanced myometrial vascularity associated with an RPOC. So that's it. On imaging, this we have already discussed. Tubular anechoic or hypoechoic areas show intensely vascular multidirectional flow, high velocity, low resistance, low pulsatility of the arterial waveform, and pulsatile high velocity venous waveform, which is typical for any AVM. Similarly, on CTMR, vascular lesion with myometrial involvement or early venous return at CT, flow void within the mass on MR. So excessive hypertrophy of the uterine arteries and the tortuous hypertrophic arterial mass, large feeding vessels, and early drainage. So new is for the treating of the AVMs. Now 26-year-old lady, she's in severe sepsis and acute kidney injury, post-dilatation curettage done few days back. So now what has happened? Now she's not really bleeding, but she has undergone gone into sepsis. So why has that happened with an acute renal shutdown? Because now what we see on the MR, this is the endometrial cavity and this is the myometrium, and we can see that there has been a perforation. So this is the diffusion weighted images. So there is restriction of diffusion. There was an abscess which has formed within the myometrium and that has secondarily perforated. So there was a focal uterine perforation with a myometrial abscess formation. So perforation can happen as a complication of all the intrauterine procedures, whether it's an IUCD insertion, dilatation, curettage, intracavity radiotherapy, or any factor where there is an instrumentation being done within the uterine cavity, it can lead to the perforation. So associated with injury to the surrounding blood vessels or viscera, bladder, bowel. Spontaneous can happen either if there is a pyometra because of underlying infection, where tuberculosis is a common cause, but this is usually a chronic presentation or an advanced malignancy. Severe pain can happen post-procedure and immediately associated with an abdominal distension. Patient may land up in shock if there is an associated hemorrhage or sepsis. So if we are suspecting a perforation, what do we see on the ultrasound? So hypoechoic collection, which is communicating with the endometrial cavity and defect in myometrium. CT, a heterogeneous collection with defect in the uterine contour with ascites, and similarly within the MR, better to evaluate that defect. So now this is a 30-year-old lady. She's post-op day 3 of LSCS and now she's having pain abdomen. So now you can see there are two entities. One is a scar dehiscence or uterine dehiscence, and one is scar rupture or uterine rupture. So we have to understand the difference between these two. When we are terming anything as rupture, then we are saying that there is a complete tear through the serosal margin as well. So this margin is also not intact. So here you can see this is the endometrial cavity. It's a postpartum uterus. It is a post-cesarean uterus. So there is subcutaneous edema. There is a scar site. There is some edema even within the parietal wall. And what is happening to the this is the uterine cavity. This is my scar site. So normally also the scar site would have some fluid. That is normal because it's just imaged post-op. But if we are seeing a defect in the wall and then this content is communicating outside into the peritoneal cavity, then it is a scar rupture, which means that rupture by definition involves the breach through the serosa. So this is a scar rupture. Now we published this paper in which we have tried to summarize this difference between uterine dehiscence and uterine rupture. So if there is a separation of the endometrium and myometrium with an intact serosa, okay, so the cavity is slightly more widened as compared to what is the normal appearance of a scar in the post-op setting. And the patient is a postpartum patient now who's clinically deteriorating. There is a bladder flap hematoma and there is may be associated with a large pelvic hematoma. Whereas if there is a complete, but here the serosa is intact. Yes, see, there is in post-cesarean, there is some fluid within the scar site. If that fluid starts increasing, the patient starts deteriorating clinically, and we start seeing a hematoma, whether it is in the utrovesical space, that is the bladder flap hematoma, or it is in the pelvic, then you start suspecting a uterine dehiscence. And if you see a clear-cut rupture, that is the serosal margin is also breached, and there is significant degree of an ascites, there is a clear-cut communication. Many times even the air foci can be seen communicating through the endometrium into the peritoneal cavity, and a significant degree of hemoperitoneum, then it's a scar rupture. And scar rupture cannot be managed conservatively. Then they have to open up the patient. So demonstration of air between the cavity and the extrauterine collection in the presence of peritoneum would be suggestive of a scar rupture, which is definitely a surgical emergency. So here we can see, now you see the difference between these two images. So you are seeing a significant degree of a hemoperitoneum here, and this is the cavity, and there is a clear-cut breach here. Here you can see that the wall is intact and there is a hematoma. Definitely there is a hematoma, but it is not that degree of a hemoperitoneum as seen in the first case. So this one is a uterine dehiscence and this one is a uterine rupture. Even though now here the fluid might not be that marked, but because it is all leaking out through the cavity into the peritoneum. So this is an emergency setting. So this was about the uterus. Then we come on to the adnexal lesion. So we have seen, this is our step 2, that the uterus was normal, and now we start examining our adnexa. So either we are not visualizing the ovary, or we are visualizing masses, whether they are cystic or solid, they are unilateral or bilateral. So depend, and there may be associated ascites plus minus, which can be a hemoperitoneum also. So the common entities are like, for example, it's a unilateral mass, typical appearance of a torsion. We'll just see what it is. Usually only minimal fluid around that torted ovary, not as very significant ascites. Tumor rupture, ascites is there. There is a background history of a tumor, or may even be a first presentation. OHS is typical setting that the patient has been given drugs for stimulation, and now there is a bilateral enlarged ovaries, ascites, and pleural effusion, tubo-ovarian abscess. So PID is a big mimicker. Please don't miss PID. That is, patient can be in severe pain. It's like really painful for the patient. Bleeding may not be that excessive, but the pain is very, very excessive in cases of PID. And hemorrhagic cyst rupture, which I'll just show the cases. So now 17-year-old female, I'm sure everybody's familiar with this, a huge adnexal solid mass. We can see peripherally some ovarian follicles which have this echogenic rim. So this has also been described as a sign that follicle which has got an echogenic rim, or on the MR it is seen as a T2 hyperintense rim, or on the NCCT as a hyperdense rim. So these kind of signs are typical for a ovarian torsion. So typical whorl along with an enlarged ovary or in a mass along with peripherally situated follicles. So this had turned out to be a large hemorrhagic cyst with ovarian torsion. So typical signs: string of pearls appearance, unilateral edematous ovary, twisted pedicle, absent arterial or venous flow. Then the severe abdominal pain, ovarian tumor cysts, predisposing factors, hypoechoic enlarged ovary, multiple follicles. So all of this, whirlpool sign. Preservation of arterial supply does not necessarily exclude torsion. Many times it gets detorted. That is also a very problematic situation. You are getting this kind of an ovarian picture, but you are not getting the whirlpool sign. You are getting some peripheral flow, but if you are getting the other signs, that is, that's an enlarged ovary, there are peripherally situated follicles, patient is giving a history of acute pain, suggests torsion, and there might be a possibility that it has undergone a detorsion. That is definitely one of the commonest findings that the surgeon gets when they operate, that torsion, detorsion, or many times torsion has persisted and after a few days the pain has subsided. So because it has now undergone a complete infarction. CT, eccentric or so it's the vascular pedicle that we need to identify and the uterine deviation to the affected site and ascites. Then MR, similar appearances. Okay. So 23-year-old lady with acute abdominal pain. Now, what are you seeing? You put your probe on the ultrasound, doing an ultrasound pelvis, and you see this kind of heteroechoic lesion, which is solid cystic, has some necrotic areas, some solid areas, different kind of a color flow. So this is the uterus, this is the left ovary. And this is the right ovary, which is seen as a cyst, because it was not so well seen with the curvilinear probe. So we attempted with the linear probe, and we can see that there is a crenated kind of a cystic lesion within the ovary. Now, this is the CT of this patient and the MR. So here, what are you seeing? This is definitely blood product. So this is hematoma or hemoperitoneum. So here you can see some differential signal also. So this is the T1 weighted image. Now you're seeing a lesion within the ovary. So this is the T2. You're seeing follicles. There is a lesion which has got characteristic of a subacute hematoma. Why? Because it's a T1 hyperintense rim and it has got a T2 and a T1 hypointense lesion within. Then there is a lesion which is within the pelvis, which is suggestive of a hematoma, T1 intermediate to bright and T2 dark. And there is free fluid, which is again T1 and T2 intermediate. So hemoperitoneum. So there is a cystic lesion within the ovary, which is suggestive of a subacute hematoma kind of appearance. There is a hematoma within the pelvis and there is hemoperitoneum. So this patient was operative, hemoperitoneum was drained and the cyst wall biopsy was suggestive of a hemorrhagic corpus luteal cyst. So this entity also all of you should be really aware of, because this is also a common acute presentation. Hemoperitoneum secondary to a corpus luteum rupture, biggest mimic ectopic pregnancy. So the UPT is very essential. This kind of a picture that you are seeing a cyst, you're seeing some peripheral vascularity around it, you're seeing a hemoperitoneum, patient is sick, she's presenting with pain. UPT is essential. If the UPT is negative and you have ruled out an ectopic pregnancy, then the most likely diagnosis is that a corpus luteum cyst has ruptured and resulted in that hemoperitoneum. Another patient, now she is presenting 10 days after the acute pain. She had an acute pain abdomen. She went somewhere in private, got some medication, pain settled to some degree, and then she went back home. And then she comes back again 10 days later. And now this cyst is, it's looking like maybe a normal ovary with some enlarged follicle, but we are seeing this hematoma kind of picture still within the pelvis. So hematoma and a resolving corpus luteum. She had a rupture at that time. It formed a hematoma, but thankfully it settled by itself. And now the patient is, with time, this hematoma will also resolve. So this is the corpus luteum rupture, typically women of reproductive age group, luteal phase of the cycle. So usually after the 14th day. So the pain is typically within this secretory cycle. So this is what we had published as a paper where they identifying the signs as a corpus luteal rupture for causes of hemoperitoneum. So these signs I've just told all of you. Just remember that if you are clear-cut seeing a discontinuity, irregularity of the wall, definitely suggests ruptures, or there is a contrast leakage. High attenuation free fluid, hyperdense foci in the adnexus, sentinel clot sign. So it's just the same concept. that there is a cyst which has ruptured, so its wall is irregular, it is bleeding, so it is having a surrounding hematoma, central clot, and then it is causing the hemoperitoneum. So those are the signs you'll see whether it's an ultrasound, CT, or MR. Again, just to show the same, so there is this irregular margin of the hemorrhagic cyst, there is a hemoperitoneum. Again, you can identify the hemoperitoneum. This is the cyst which has got this irregular margin, and you've got the sentinel clot. Again, the MR features, so see how nicely you can see. This is the follicle on T2 weighted image. This is the cyst, and you can clearly see even that blood leaking out. So this was the corpuscular cyst which was rupturing, and this was the bleed which was forming that hematoma, and then this is the free hemoperitoneum, and this is the normal right-sided ovary. So this kind of appearance also is typical for a rupture. Now, 30-year-old lady, progressive abdominal distension, and now what are we seeing? There is a tumor which is solid cystic, there is gross ascites, but now this fat component is also having free within the peritoneum. So this is a ovarian teratoma, immature teratoma, sorry, with rupture. Rupture of benign teratoma. Rupture may present as severe abdominal pain, shock, and because of the signs of peritonitis. Now, again, same thing. Fat may be seen within the bladder or echogenic strands. Okay, I'll just show the case. Now, this is a 26-year-old lady. She had pain, lower abdomen, and UTI. So she was having recurrent UTI. So what are you seeing? You are seeing this was actually a private film which she was carrying. So there was some ovarian cyst which was reported 1 week back. Now she's presenting with recurrent UTI, and what are we seeing? Think. So see, this is the bladder, and this bladder has got some echogenic contents within, and there is something echogenic which is extending out. So where is it extending out through? It is the urethra. So this was actually the hair which was extending out into through the urethra. And this was the initial CT of the patient. So here we can see that there are bilateral adnexal lesions which are showing fat and calcification within. And this is the cystoscopic image. Sorry, the CT urography image, and here we can see that part of this lesion is perforated into the bladder, and this is the lesion which has gone inside the bladder. So there is some calcification fat within this tumor within the bladder, and this is the cystoscopic image where we can see the hair within the urinary bladder. So a dermoid which is perforated into the bladder, and then the hair is going out through the urethra. So that is known as plemiction, that is bilateral ovarian teratomas, and the right one had invaded into the bladder. Clinical presentation of plemiction, that is passage of hair into the urine, and then again UTI, pyuria, hematuria from the dermoid cyst. It is believed that either chronic leakage because of a non-malignant fistulization with the adjacent viscera, or there's a torsion which leads to ischemic focal necrosis and leakage formation of fistula, but not really sure of what has. 31-year-old ovulation induction therapy, even the history is very suggestive. Acute pain, abdomen, nausea, vomiting. Patient comes to us primarily for the extent, how much. So the measurement of the size of the lesions, ascites, and the degree of effusion is what we need to tell. So OHSS, that is ovarian hyperstimulation syndrome. And it is a complication of ART. Just remember one line, spontaneous OHSS. So everybody knows this setting where the patient has been given in treatment for infertility, but non-iatrogenic, and especially in the pediatric or adolescent age group, what is the cause? Hypothyroidism or beta-HCG secreting tumors. So these are two important causes which all of us should be aware that they can also lead to an OHSS. So many times a small child who's presenting with huge ovarian cysts is then the cause cannot be OHSS because of a stimulation. So that stimulation is from the central pituitary. So either there was a hypothyroidism, or there's a pituitary adenoma, or there is a beta-HCG secreting tumor. So that is then the central cause needs to be evaluated. So always remember there are causes of spontaneous OHSS also. Now 32-year-old, fever, pain, abdomen, discharge per vaginum. This is very important many a times. See, this kind of appearance, you can think hematoma or you can think abscess. Those are the two most differentials, with the appearances of a multilocular cystic lesion, which has some septations which are thin and thick, which is an intermediate kind of a mild vascularity. There are cystic lesions which has debris within. On CT, multilocular enhancing cystic lesions, and there is lots of fat stranding inflammation surrounding, and typical of a pelvic inflammatory disease. So this can be endometritis, salpingitis, TO abscess, pyosalpinx, peritonitis, but severe pain, vaginal discharge, and initial settings, if it's only a cervicitis, in fact, our imaging may also be normal. Ultrasound typical appearances, thickened endometrium, hydropyosalpinx, TO abscesses. This all we have seen, thickened uterosacral ligament, same appearance on the MR as well. So let's see some case scenarios. Now, 19-year-old lady with acute lower abdominal pain. Okay, so this is the endometrium and this is the adnexa. Okay, and this is the MR appearance. So this is the T2 weighted image and this is the post-contrast T1 weighted image. This is one ovary. This is the other lesion that we were seeing. So anybody would like to take a guess? Yeah, so this is a right ovarian torsion with hemorrhagic infarction. So here, this classical appearance where you're seeing follicles in the periphery, this kind of an appearance, it is very, very typical for only two things. Either there is a massive ovarian edema or there is a torsion with hemorrhagic infarction. So what is actually massive ovarian edema? So the differentiation from torsion is also not very clear, but it's that the affected ovary remains viable without infarction. So in torsion, what we classically say is that the arterial supply is eventually compromised. And it is this massive ovarian edema is more on the right side because the right ovarian pressure vein is on a higher pressure as it is draining directly into the IVC. And this is the appearance is the same, peripheral cyst representing peripherally displaced follicles. And the etiology is not really clear, and many times both of them just stay as differentials. Now in this case, try and identify the findings. Anybody? So
There is a little bit of a lag, Smitha, if we can just give them a few seconds.
Yes, yes. So there is a right adnexal lesion. This is the uterus. This is the left ovary. And just think of this ultrasound appearance.
No responses yet.
Okay. So acute appendicitis, so the blind ending tubular structure with aperistaltic, dilated, thick wall. So those, but don't always think gynecological causes. Even the right iliac fossa needs to be evaluated in terms of the bowel pathology, diverticulitis, appendicitis, epiploic appendicitis, or urological causes, calculus. So all that needs to be evaluated. Yes, gynecological causes are also important, but think both ways. 25-year-old lady, known case of ITP. So she has a predisposition to bleeding tendencies with acute pain in the left iliac fossa. So here, just try and see the image. These are the CCT images. You try and identify what is this, then what is this. Then we have an MR. Very similar to the case I had just shown. So try making a diagnosis. She's unmarried. She has a bleeding disorder. You can write in the chat box whatever you think. Likely diagnosis.
I think we'll give a few seconds, and
yes.
There were some answers to your previous case, PID, which I think is a fair thought. No responses yet. None.
So hemoperitoneum secondary to hemorrhagic cyst rupture in case of ITP. So see, when these patients who have bleeding disorders, they very frequently, you can see this scan is actually 2015, but even till in the last 4-5 years, this patient had frequently presented with these episodes. Once a year, once in 6 months, she presents with this kind of an appearance. So what are we seeing? We are seeing hemoperitoneum. We are seeing a sentinel clot or hematoma kind of appearance, and there is ill-defined hyperdensity within this And when we have an MR correlate, so this subacute hematoma kind of appearance adjacent to a ovarian cyst, which also has hemorrhagic component. So this all correlates to likely possibility of a hemorrhagic cyst rupture with hemoperitoneum. Now, postpartum state, fever and pain abdomen. Okay, so now this is the uterine cavity in the postpartum state. And here you can see there is the postpartum cesarean. There is subcutaneous edema here. There is a scar site. Then something is happening here. This is the bladder. This is the uterus. What are we seeing here? And remember, now she is having fever. And you can see the size of the uterine cavity. So even though I have not really told you that it is what post-op day, but it cannot be an immediate post-op. It is at least 7 to 10 days post-op because the size of the uterine cavity has significantly decreased.
So we have many responses. Scar dehiscence, Dr. Prabha is saying dehiscence, scar dehiscence. Dr. Ayush, scar site abscess with endometritis, uterine rupture.
Yes.
2 attendees, scar site infection
Yes,
with abscess.
Yeah, so post-cesarean hematoma or abscess formation, yes. And for the scar site, actually, dehiscence would be the correct term. It is not really a rupture because we are still seeing the intact margin. So there is definitely a hematoma formation. Yes, it can be an infected hematoma or abscess. So that is also correct. 22-year-old lady with lower abdomen heaviness since 1 year and acute lower abdominal pain. So see carefully, there is a lesion in the left adnexine going into the pouch of Douglas. It is a complex lesion. It is appearing predominantly cystic because there is a through transmission. And there is, just try and identify this echogenic component. Now the T1 weighted image, hyperintense lesion, some hypointense components within. And then this is its T2 correlate. She has a lower abdominal heaviness since 1 year, but now she has an acute lower abdominal pain.
We'll just give the attendees a few more seconds. So we have one response, hemorrhagic cyst.
Okay. See, the fact that some degree of correlation with the lower abdominal heaviness, I'm sorry, I didn't have the T1 fat sat image in this case. So this is what? Definitely appearance of a torsion. Why? Because the uterus is deviated. She's having acute abdominal pain. The follicles are studied in the periphery. There are T2 hypointense rim to it. And there is a cyst within, which is having T1 bright contains T2 bright and some T2 hypointense. On the ultrasound correlate, there is this echogenic dots and dashes appearance as well. So morphology is like that of a dermoid cyst and which has undergone torsion. Now, 28-year-old, acute pain, 2 days, abdominal distension 1 month, and these are the tumor marker levels. So this is the uterine cavity. This is the mass lesion. Now here you can see. See what I want you to identify is this thing. What is happening here? You can see the, I didn't press the button, but it's actually what we are seeing is that a peritonitis has happened because if this is a tumor and there is, the patient has got, it's a solid cystic mass. Now she has got this extensive ascites, which again has echos within, and it has called this diffuse peritoneal enhancement, pain abdomen. We had suggested that either there is an entire degree of peritonitis which has happened either because of a rupture, we could not really demonstrate any rupture, or there is a peritoneal seeding of the disease entirely. But usually in peritoneal seeding also, what we normally get is discrete peritoneal deposits. This kind of an enhancement is very unusual. And on staging laparotomy, it turned out to be a ruptured germ cell tumor. 29-year-old female with fever and pelvic pain. So now think. So this is the ultrasound image, a cystic mass with thick walls. Here are the MR images, T2, post-contrast T1, and the ADC map. So the right-sided, you can see multilocular cystic lesion with thick walls, thick enhancing walls. Some of them are irregular, and extensive diffusion restriction, fever, and pelvic pain, reproductive age group.
There is a response PID by Dr. Anushri, PID.
Yeah, so tuber-ovarian abscess or PID. Another case, so this is, you can see a typical S-shaped or tubular lesion which has got incomplete septation, some internal debris within. And this was actually another patient who had actually presented, and then she was operated immediately because the pain was so severe. Patient was like, it's not even lying down on the bed for the ultrasound. It was so difficult. And these are the bilateral tubular myosalpinx with, she was operated and these were removed. 32-year-old extensive bleeding post DNC, 1 month back, now beta HCG 50. So here you can see, try and identify whether you think the mass is within the endometrial cavity. It has got a degree of vascularity. Here, try and identify, this is the lesion, this is the lesion, beta HCG 50.
So we have different responses, AVM, grade 2 RPOC, 2 responses for AVM.
Okay, ma'am. So here it is a highly vascular RPOCC. AVMs, like I had previously also explained, isolated AVM can, yes, happen. But when you are seeing echogenic contents along with this degree of vascularity, when an AVM will form, then most of the times it is associated, if you're seeing an AVM along with the echogenic contents and with a very high beta HCG, then it is a spectrum of the GTN. Usually RPOCs with an AVM is very unusual. Then it has those enhanced myometrial vascularity, which is in the periphery. And if you are seeing such large echogenic content, and even here this intermediate signal content, which is distending the endometrial cavity with this kind of a vascularity, then grade 2 RPOC is the correct diagnosis, grade 2 or grade 3. So now 34-year-old lady, MTP at 16 weeks, period of gestation. Now 2 days post DNC, she had abdominal distension, pain abdomen, and she has obstipation. So I'll just show this case. Now what is happening here is that this is the endometrial, this is the uterus, sorry. This is all air within this uterine cavity. So here what was happening was along the right connu, we could trace this entire air through this part of the connu. And in addition, this was the TVS image where we could see that there was also some ascites and then the free air which was communicating outside. Now this was the CT she underwent because there was pain abdomen along with the obstipation. And here we can see that there are small bowel loops which are dilated. And in addition, there is free air, there is a pneumoperitoneum, and this is the uterine cavity. Now, what are we seeing? In this lower part, we are seeing some motile lucency along with some hyperdense contents and fluid air foci along with the hyperdense foci. And then this entire air foci, which we could see even on the ultrasound as from the right uterine cavity, right connu, this was going out into the peritoneal cavity. So the zoomed image to show the same. So here we can see this is within the uterine cavity, mottled appearance, hyperdense, and within the air foci. So this was actually retained products of conception with fetal bones. There was a uterine perforation at the right cornu, and there was a rectosigmoid perforation, which had led to the pneumoperitoneum. So this was the bony RPCs, which were these retained products that had been taken out. And there was a rectosigmoid perforation, and along with the uterine perforation, which had happened. So to conclude, the common clinical presentation is an acute pelvic pain and bleeding per vagina. Causes, as we know, gynecological, gastrointestinal, and urological all need to be kept in mind when the patient is presenting. First, most baseline imaging modality is ultrasound. Please be free to use your TVS probe. That gives you a much greater resolution, but use all probes. So if the patient is unmarried or not giving consent for TVS, then TRUS can be done. Linear probes can be used. So try and make as much of a diagnosis possible on the ultrasound. And then definitely a complementary role of CT, MR problem solving in the indeterminate ultrasound or CT findings. So these are my references, and I would like to thank Professor Shivanand for all the UAE images. Thank you.
Thank you very much, Dr. Smita, for walking us through the entire gamut of gynecological emergencies. And thanks for spending quite a bit of time on making the distinction between RPOC, AVM, and GTN. I know that's often a source of confusion. In fact, I have a few questions on that subject. I think you addressed some of them towards the end when you showed that case. But just to clarify, there's one question. Enhanced myometrial vascularity and uterine AVM, is it the same thing? And do you use any velocity criteria for making the diagnosis of a uterine AVM?
No, we really don't use the velocity criteria. In terms of the distinction, the literature which has recently described the entity of enhanced myometrial vascularity actually correlates it to the small nidus or these small malformations which are happening around the RPOC. So those highly vascular RPOCs, actually, it is said that the trophoblastic tissue initiates that reaction in such a way that those small niduses form within the endometrial myometrial trophoblastic reaction which is happening. So those are actually they are small AVMs only, but they are numerous and they are along that trophoblastic tissue. So that is why they have now been termed as enhanced myometrial vascularity, so as not to raise the concern that they are AVMs in that sense. Because when we use the term AVM, then that connotation becomes like it's an AVM, so it needs to be treated by a UAE. And whereas the enhanced myometrial vascularity can be very well managed conservatively, the patient can undergo a medical management of the retained products. And many times we have cases where we have documented a complete resolution of that entire vascularity over a period of 3 months or 6 months, and it just disappears. Ma'am, you're muted.
Then another question, how to differentiate RPOC in cervix from cervical pregnancy when the fetal pole is not seen?
RPOC from cervical pregnancy. See, if the fetal pole is not seen, then in terms of the management also, if it is, we are seeing a typical appearance of a gestational sac along with the yolk sac. So that is diagnostic of a cervical pregnancy. Whereas a retained products, retained products would not really happen in the cervix. Retained products would happen in the endometrial cavity where the implantation has happened. If it is seen in the lower segment, then it is at the scar site. So what is a usual problem is the scar site retained products or the scar site pregnancy, which is just recently, it's a pregnancy. So those differentials, yes, become important. Then the clinical correlation, the beta HCG level, any previous imaging available. The classic appearance of a pregnancy, whether it is at the scar site or the cervical area, would be that there's a gestational sac with a thick trophoblastic reaction with internal yolk sac or fetal pole. If that is not seen, then it has to be correlated with the appearance of the previous imaging or the beta HCG levels. But retained products of conception usually will not really happen in the cervix. That will not happen.
True, it's probably in progress. Products that are going to be. So I think there would be, the history would be suggestive. There's another question, explain the emergency myometrial lesions. I think we'll leave that for another talk since we already passed your time and I don't want to keep you for any longer than this. Thank you very much for these excellent cases and great discussion. Thanks, Dr. Smitha. So I will now move on to my talk, which is on genitourinary emergencies. I'll just share my screen. So can you all see my screen?
Yes, ma'am.
Okay, wonderful. So I basically am a consultant at Teleradiology Solutions, and I've been doing emergency teleradiology for the last almost 2 decades. I'm going to, this is going to be slightly different from the previous talk in the sense that it is more of a rapid fire case-based review. And I would request you to just type in your responses so that we can move along fast and see as many cases as we can. And if you have any questions, I'll just address them maybe at the end of the talk or right away. So I'm just going to put my video off, that way you don't get disturbed. And let's go to case 1. This is 2 axial CT images of an 18-year-old female presenting with right upper and lower abdominal pain. So right upper and lower abdominal pain. I just want you to look at the images and mention the key finding. There is only one finding, and this is a talk on genitourinary emergencies. Since we need to move a little fast, I know there's a lag, I will just go on. So basically the key finding is the asymmetry in the nephrogram. As you notice on the right side, it is lagging behind the left side. You're seeing the contrast enhancement of the right kidney in the corticomedullary phase, unlike the tubulointerstitial phase in the left kidney. So I have one response saying delayed pyelogram, no pyelogram. Well, it's not, it's a delayed nephrogram. So, on the right side. So, so what are the possibilities that could result in a delayed right nephrogram? Yeah, excellent. There's one correct response, delayed right nephrogram. So basically any kind of either flow obstruction to the inflow, arterial inflow, obstruction to the outflow, a venous outflow obstruction, or a urinary tract obstruction can lead to this kind of appearance. And obstructive uropathy is the most common cause. Rarely, if you have a large subcapsular collection because of the mass effect, that can also result in diminished perfusion to the kidney that's surrounded by the large subcapsular collection, and also result in a similar finding. But of course, in that case, you'll see a large subcapsular collection. So let's not jump to conclusions. I see responses, ischemia, ureteric obstruction. Yes, ureteric obstruction is right. If you are an astute observer, you can see there is a tiny calcific density at the right uretrovesical junction. And this is a case of obstructive uropathy. Please note that sometimes calculi are seen on the reformatted images. Like on this one on axial, the thinner sections, you see it very well, but not so well on the coronal reformatted image. So look at all the available reformats. And usually when you have obstruction because of the elevated renal pelvic pressure, it leads to prolongation of the corticomedullary phase. You might see a persistent dense nephrogram if you were to take a delayed image. You might see mild pelvic or calaceal dilatation. And why the sign is useful is because in acute obstruction where there is not enough time for development of hydroureteronephrosis, this asymmetry in the nephrogram can be a very helpful pointer. Of course, in this case, you're also seeing some perinephric fat stranding and minimal fluid. A clue, there is a tiny non-obstructing calculus. And when you go and trace the ureter, you see an obstructing calculus at the left uretrovesical junction. Now, another patient with flank pain on the left side, and I just want you to carefully look at the other signs of urinary tract obstruction on non-contrast CTs. Like in this one, there is mild fullness of the callaceal system, there is perinephric edema, and as you go further down, there is periureteric edema also. And notice how the kidney is slightly swollen compared to the normal side. And another very subtle finding is the diminished attenuation of the renal pyramids, which look dense in the normal kidney, but they look sort of similar in density. The entire kidney looks alike without the dense pyramids. That's another sign of obstruction and renal edema. You may also see a perinephric fluid extending into the pararenal space in a case of forniceal rupture because of obstruction and high pressure. And as I mentioned, the calculi may be seen on another reformation. So look at all the available reformatted images. Now, case 2, I just want you to quickly mention which one is the calculus. I've marked A, B, C, D. There are, these calcific densities, 3 on the first image, another 3 on the second. So which one is the calculus? Very simple. So what are the signs that you look for to make the distinction between a calculus and a phlebolith? Excellent. So I'm getting C. That is absolutely the correct response. And the reason is because you're seeing this soft tissue rim around the calcific density, which is the edematous ureter around the impacted calculus in the terminal ureter. Also, a phlebolith is seen more lateral and posterior to the uretrovesical junction. And you may also see the tail or comet sign. Also, it's very useful always, when in doubt, just trace the ureter back and forth and see where that calcific density is. And you can clearly see here on the left side, the ureter is here and you see the calcific density. And so that's the calculus. Now, case 3 is a patient, a young female, 40-year-old with global pain, hernia repair 4 days ago. And I just want you to tell me what the diagnosis is. What is the key finding? What are the key findings? There are 2 of them. And what is your diagnosis? Firstly, I have not mentioned which side is abnormal. So you have to tell me which is the abnormal side, right or left. Now, it's on the same theme. We are talking about asymmetry in the nephrogram. So somebody has mentioned a left staghorn calculus. Be very careful when you're looking at contrast-enhanced examinations. This is a contrast-enhanced study. So, excellent. So we have Dr. Kanimozi mentioning renal vein thrombus, 2 other doctors mentioning renal vein thrombosis on the right side, and that is the correct answer. You are seeing a persistence of the corticomedullary phase on the right side with some perinephric fat stranding. Now, one of the other causes of this asymmetry in the nephrogram is obstruction to the outflow of blood, which is through the renal vein, and there is a filling defect in the right renal vein extending into the IVC. That is resulting in this asymmetry in the nephrogram and preventing contrast excretion as the function is delayed on the right side and normal functioning kidney on the left side. So that's not a staghorn calculus. The most common etiology is membranous glomerulonephritis. Of course, when you see a renal vein thrombus, you must always exclude an underlying renal tumor. And pulmonary thromboembolism is a common complication of these thrombi. And the management in absence of a tumor is anticoagulation. And I've listed the other causes of renal vein thrombosis. A companion case, in this case, I'll just quickly mention that you can again see that there is a very subtle difference in enhancement of the 2 kidneys. There is mild prominence of the pelvic callaceal system, but I didn't see any stone. However, I do notice there is this heterogeneous lesion in the lower pole of the right kidney, and there is this subtle filling defect in the IVC and the right renal vein. So this is a case of a renal cell neoplasm with thrombosis of the renal vein and the IVC, resulting in these findings. Now, this patient with left flank pain, I want you to just make the key findings and what is the diagnosis. So you're seeing absent enhancement of almost the entire left kidney, right? With just a few normal areas of enhancement. And somebody has correctly mentioned it's renal infarction. The left kidney is infarcted. It's devascularized. And the causes, as you can see, there is the left renal stent, and there is a thrombus just distal to the left renal stent, causing this infarction of the pretty much entire left kidney. And an important sign that is being mentioned in the chat box, and I'm very delighted to see, is the cortical rim sign. So this cortical rim sign helps make the distinction between, if you were to see a segmental infarct, a distinction between pyelonephritis and an infarction. In pyelonephritis, typically, you will not see the cortical rim sign, which you would see in a case of a renal infarction. And that's because a thin margin of peripheral enhancement of the outer renal cortex continues to occur from collateral flow from capsular arteries, even when the renal artery is occluded. And this kidney subsequently underwent atrophy, and the scan was acquired about 2 years later. Now, this patient is a young female who underwent an emergency, sorry for the spelling here, emergency C-section, and had a past medical history of chronic hypertension, preeclampsia. She was admitted to labor and delivery because she was having massive vaginal bleeding and pain. So I want you to mention what the key finding is that is glaring at you, and what do you think is the diagnosis? Now, this one image is not enough based on this findings, so it would be a differential diagnosis based on what you're seeing, the sign that you're seeing. So I'm just, yes, excellent. So striated nephrogram, fantastic. And there is a list of differential possibilities when you see bilateral striated nephrogram. And that is, it could be bilateral acute pyelonephritis, but there is no fat stranding around the kidneys or any other inflammation. It could be acute tubular necrosis, either toxic or secondary to ischemia from hypotension or cardiovascular collapse or sepsis. Or you can see in cases of rhabdomyolysis or myeloma, when there is tubular obstruction, you can get the striated nephrogram. And this appearance can also be seen in autosomal recessive polycystic kidney disease. Now, I'm going to show you the complete data set on this patient so that you can tell me what is the real cause of the striated nephrogram. So if you look at this, of course, the gallstones are there, but just look at the striated nephrogram, and let's forget that for a little while. You're seeing that the bowel loops are diffusely dilated, fluid-filled. This is an ileus-like picture. And then you see the postpartum uterus that's enlarged. And then you see this hyperdense fluid collection in the anterior pelvic wall, in the extraperitoneal space, and a drain has been placed because of the large amount of hematoma. So this patient actually has striated nephrogram due to hypotension and ischemic acute tubular necrosis. Our next case is an elderly female with fever, chills. Her urine analysis was negative. She has history of dye allergy, and that was discovered when she had a cardiac catheterization 2 weeks ago when she developed anaphylaxis. She also had normal renal functions at the time of cardiac catheterization, and it's observed now when she presented that her renal functions are not normal. Her creatinine is elevated. So what is the finding? First, is it a contrast-enhanced study, or did we not administer IV contrast on this examination? Yes, no. Yes, IV contrast, no IV contrast. Yeah, good. So somebody has mentioned this patient has developed acute renal failure. Yes, that is correct. And that is correct. It is a non-contrast CT, and you're seeing a persistent nephrogram. So there is no contrast that has been administered, and this is a case of post-contrast acute kidney injury, where you're seeing a global persistent nephrogram lasting more than 24 hours due to tubular obstruction of ATN. This is not a case of mechanical obstruction because we don't see any dilatation of the pelvic-alaceal system. And acute renal failure occurring within 48 hours of exposure to intravascular contrast media can be called post-contrast acute kidney injury. I must say that this terminology, contrast-induced nephropathy, is controversial, as there are numerous articles that mention how it is not really causative. It is more of just a weak association, and there are other contributing factors. So patients who have normal renal functions and are given contrast rarely develop contrast-induced nephropathy. It's people with risk factors or underlying baseline renal function abnormality that develop acute kidney injury. Now, this patient, interesting one, 48-year-old male who presents with acute renal injury. I've just put the height and weight of this patient because, as you notice, I have two images. This is the right kidney, that's the left kidney, and the right kidney is 13.7 centimeter in length, and the left kidney is 14.6 centimeter in length. So the kidneys are enlarged, and you can compare, you can see how the echogenicity is. So there is increased echogenicity. You can see that the accentuation between the renal cortex and the pyramids is increased. The renal cortex appears slightly more echogenic. So patient has bilateral echogenic kidneys, which are enlarged, and has acute renal injury. So one important finding that you must mention when you are presented with this history and you must look for is the presence of hydronephrosis. You want to make sure that the patient doesn't have obstructive cause as the cause for acute renal injury. And yes, Dr. Sarangi, excellent. So acute kidney injury, enlarged echogenic kidneys on ultrasound, most likely diabetic nephropathy. Excellent. And the other possibilities, it could be acute nephritis of other etiologies, acute tubular necrosis, vasculitis, HIV nephropathy, or infiltrative processes that can result in enlarged echogenic kidneys. Now, this patient has right upper quadrant pain with fever. And please, I have images of the right kidney, longitudinal image, transverse image of the right kidney at the upper pole, at the lower pole. And this is another image of the right kidney. I want you to pay close attention. And I've put in an image from the literature, which the images show something which would have been seen in this case had I done this particular power Doppler study on this kidney. So patient has fever, has right upper quadrant pain. And unfortunately, this finding was missed. Lobar nephronia. Yeah, excellent, Dr. Sarangi. Yes, excellent. So this, what you're seeing is an area of increased echogenicity in the upper pole of the right kidney, which is seen very well in the transverse image. And you contrast that with the axial image of the lower pole of the right kidney. And there is loss of flow within this region, or diminished flow, I must say. There is no fluid collection per se. And as I mentioned, this finding was missed. So the patient underwent a CT, and the contrast-enhanced CT demonstrates a focal hypodense area in the superior pole of the right kidney. There is also some uroepithelial thickening involving the right renal pelvis, the ureter, with some adjacent fat stranding. You can see the enhancing uroepithelium. And the patient has been having pain for 2 weeks, fever, and this is a case of pyelonephritis, possibly acute lobar nephronia. So in pyelonephritis, you can see the wedge-shaped or streaky areas of diminished enhancement on the nephrographic phase. You may see delayed or persistent enhancement if you were to do a delayed phase image. So these hypodense areas may demonstrate delayed enhancement while the normal kidney contrast washes off. And the CT findings typically resolve over a month or longer, while the urine specimens become sterile within a few hours of antibiotics. And the fever is usually gone if the bug responds to antibiotics within 1 to 2 days. The other causes of interstitial nephritis are, of course, drugs, granulomatous diseases. There are metabolic conditions and immunologically mediated mechanisms. Now, lobar nephronia is typically described in pediatric age, but you can see in adults also, typically women with risk factors, diabetes, and this is basically an intermediary stage between pyelonephritis and abscess. This is not quite a frank abscess yet, as you don't see a fluid attenuation in that region. And UTIs are the most common acute urological emergencies, and you do not need to image them routinely, except for maybe sonography, because you want to exclude an underlying obstructive cause for pyelonephritis, because if there's obstruction and there is infection, then that would require emergency drainage. But in case, such as in this one, when there is no response to therapy or there is atypical clinical presentation or patient is very sick, then they need to be imaged. Typically, it's a retrograde spread from the bladder, but sometimes you can also have hematogenous spread to the kidneys. Another patient with right flank pain and fever. In this case, you can see a more hypodense area compared to the previous study, which is a renal abscess, and it has extended into the subcapsular location. You see a subcapsular abscess, and there is a good amount of perinephric inflammation. So keep your suspicion high for complications of UTI, particularly in diabetics or when there is poor response. This patient, young female, a poorly controlled diabetic, has been febrile for almost 3 weeks, is very sick and septic. Apart from the effusions in the chest, pericardial pleural, you can see multiple abscesses in the spleen. And when you scan the kidneys, you can see frank abscesses now in the left kidney. And you can see how this is looking like a fluid collection and extending into the perinephric space. And 8 ml of pus was aspirated from this left kidney. And because patient family member was MDR positive TB 3 years ago, the TB tests were done and they were all negative. And pus was cultured, it was positive for E. coli. Now, this patient, a 68-year-old male with abdominal pain, elevated lactic acid, was hypotensive sick. And sick patient, they wanted to rule out ischemic bowel. And this is a classic case of emphysematous pyelonephritis. You can see large complex air collection within the right kidney extending into the perinephric space, as well as the retroperitoneum, case of emphysematous pyelonephritis. And this is rare, but it's a life-threatening necrotizing infection caused by gas-producing organisms. The majority of the patients are diabetics. Poorly controlled usually might have underlying urinary tract obstruction, and commonly seen in females. These patients are very sick. They can rapidly progress to septic shock. Now, the differential when you see this kind of a picture is this could be localized gas-forming infection in any of the surrounding tissues and organs, or there could be fistula formation between the urinary tract and a hollow viscus that can lead to this appearance. But of course, this is classic. As you can see, the epicenter of the lesion is within the right kidney. And it has been classified, and the basis of this classification is to guide therapy. And as the current trends are, it is medical therapy is always tried first. And if it's maybe class 2, where you see parenchymal gas, you may want to do percutaneous drainage if there is poor response to antibiotics. And if there is extension beyond the kidney into the perinephric or the pararenal spaces, perhaps combined with percutaneous drainage, and in case of failure, a nephrectomy may be performed. Now, this classic picture of emphysematous cystitis, again, a diabetic female, and you can see that there is intramural air within the urinary bladder. Sometimes you may see within the bladder lumen only, and make sure that this is not that. In that case, it is not post-catheterization. But in this case, you can see air in the non-dependent portion of the UB wall and the dependent portion. So this is a case of emphysematous cystitis, again, elderly women with diabetics. And these signs and symptoms can be quite similar to a routine cystitis. So you just need to suspect if patient is a diabetic And these patients can also become septic. And again, antibiotics, control of diabetes, and bladder drainage is how this is treated. And surgical intervention is needed only if the response is not there to the conservative management. I wanted to put these two cases just to show, because I've seen at quite a few cases of xanthogranulomatous pyelonephritis in my practice. And all these patients presented with, these are two different patients, first one, and this is the second one, with flank pain and fever. So they got imaged, and what you can see are basically these cystic multiloculated hypodense areas within an enlarged left kidney, and the capsular, there is extension of the collection into the subcapsular space, perinephric space, also involving the splenic parenchyma, so adjacent organ involvement, and the renal pelvis is dilated, and there is a tiny obstructing calculus. So the classic bear paw sign that is described for XGP on cross-sectional imaging. And another case where you have the classic staghorn calculus, and again, these hypodense collections in the enlarged right kidney and a thinned out renal parenchyma. So the bear paw sign that is seen very well here. Case of prostatitis with abscess formation and some seminal vesiculitis and cystitis, not to forget that. And this patient is a 13-year-old, 12-year-old male, has drainage from the abdominal navel area. And thank you. I just saw the responses. A great job, bear paw sign, excellent. And so this patient has drainage from the navel area. I've put the representative axial images and the sagittal reformatted image. So what are you seeing here? This is a midline sagittal image, as you can make out from the spine and the bladder. And the drainage is from the navel area. So that's the area of focus. The question is this a subcutaneous abscess, an abdominal wall abscess extending intra-abdominally, or is there something more to it? And what you can see, yes, excellent. It's a urachal sinus that's infected. Wonderful. So this is basically a spectrum of urachal remnant disease, an excellent review article in Radiographics. And our picture is that of an infected umbilical urachal sinus, as you can see here. This is infected, say, stranding, and it's a urachal sinus. So majority of these patients remain asymptomatic, and they become symptomatic when they develop infection. And when they're infected, they demonstrate complex echoes on sonography, sometimes variable contrast enhancement, and usually you must do a percutaneous biopsy or aspiration for diagnosis, and total removal of the cyst wall is also essential so that there is no recurrence, and also because it is sometimes difficult to distinguish infected urachal remnant from urachal carcinoma. So if you are seeing, if you have history of hematuria or you see mural nodularity and calcification at CT, you may say that this is a urachal carcinoma, but if you don't, you cannot exclude one. So that's why you need to do the biopsy. Now, this 11-year-old male has left flank pain and a renal colic. So I have the sagittal and transverse images of the left kidney. And this is the left kidney. I'm just going to outline that for you since these are the representative images. This is the left kidney. And patient has acute onset renal colic. So you can see there is no hydronephrosis in the left kidney. And there is this hypoechoic area within the left kidney. The patient, I think for some reason, underwent a CT because a mass was suspected by the resident on call. And the CT demonstrates a classic case of a subcapsular hematoma. You can see this hematoma. The density is 76 Hounsfield units. It's deforming the left kidney. And what I want to point out is the slightly persistent left nephrogram. You remember we had mentioned one differential as a large subcapsular collection that's causing extrinsic mass effect and can also result in diminished renal function. So when you do a delayed image, the nephrogram is still persisting. Now, more cases of renal hemorrhage, and in this case, an elderly female with abdominal pain. And what you are seeing is basically a fat-containing tumor in the left kidney. There is also a large pseudoaneurysm in the left kidney. And there is a large amount of perinephric and pararenal hematoma extending into the retroperitoneal spaces. Yeah, thank you. I see page kidney. Yeah, that's good. Ruptured, yeah, wonderful. Ruptured AML. Excellent. So this is a case of a ruptured angiomyolipoma, and there is an aneurysm which has ruptured, and there is a large hematoma. So it's a most common benign solid renal neoplasm, and because the blood vessels are dysmorphic, and they may develop pseudoaneurysms. And please note that these lesions may be devoid of fat or may contain very small amounts of fat, and in those cases can be mistaken for renal cell cancer. But fat-containing renal cell cancers also contain calcification. So if you see calcification, then you can lean more towards a renal cell cancer. They may be associated with tuberous sclerosis complex, could be bilateral in that case. Usually, if they're small, patients are asymptomatic, you can just leave them alone. But if the size is 4 centimeters or larger, or you have an aneurysm that is 5 millimeters or larger, you need to intervene by either renal artery embolization and partial nephrectomy. And of course, in case of surgery, you have to remove the tumor or partial nephrectomy or catheter embolization. Another companion case of an AML on the left side, and this beautifully demonstrates the fact that this large neoplasm, which is exophytic, is originating from the left kidney, and you can make it out by the claw sign. And there is also the feeding vessel sign, which is seen on this one. You just have to trust me. I'm sorry, I should have put the cine for this one, but there is active contrast extravasation and just enormous amount of blood in the retroperitoneum as a result of this ruptured AML. Now, I have two patients with the same pathology. This patient is septic, and this patient has undergone a motor vehicular accident. These 3 images of a young patient who has undergone a motor vehicular accident, and these 3 images from a patient who's septic. You can make out there is bilateral pneumonia in the visualized lower lungs. And I have just put the representative images. You can focus in the renal, suprarenal area. And in this patient, acute pain is primarily on the right side. We did not see any other abnormality. And you can compare the 2 adrenals, excellent adrenal hematoma. So there's a large adrenal hematoma on the left side in a septic patient, and there is a hematoma on the right side in a patient post-motor vehicular accident, and that was the only traumatic injury that was seen in this patient. Trauma is a common cause of unilateral adrenal hemorrhage. And when you see bilateral adrenal hemorrhages, it's usually due to thrombosis or adrenal vein spasm in patients who are septic, have DIC, or are using steroids or have coagulopathy. And we are quite aware of the fact that we see this entity in neonates due to birth trauma, sepsis, or hypoxia who are born to diabetic mothers. And the clinical signs are quite non-specific. They could be asymptomatic or may present with pain, such as in our case with who had a motor vehicular accident. But if you have bilateral large adrenal hematomas, they can present with adrenal insufficiency. So a septic patient, please keep this in mind, the presence of adrenal hematoma. So this patient is a young male, 11-year-old, has presented with left testicular pain and swelling for 45 minutes. So I have the transverse image of the right and left testicle, right and left, scrotum side by side, grayscale with the color Doppler. So the moment you see this, your diagnosis should be obvious in a patient with acute onset pain and swelling. Excellent. Oh, wonderful. Testicular torsion. Great. So what you should look for is the spermatic cord. So you follow the epididymis, the spermatic cord, and you put a color Doppler tracing on that, which is avascular. And there is also scrotal wall edema. Excellent. That is, you can see the asymmetry. And there is also a small amount of hydrocele. And you see this twisted spermatic cord with no vascularity. There are other signs which I want you to study carefully so that when you do your scans, you come across as very smart. I'm sure you already know, you seem to be answering all the cases very well, but just for the sake of all the signs, you can see I've measured the thickness of the scrotal wall. The left side is thickened. The testicle is hypoechoic. There is a hydrocele and it is avascular. Now, the other sign that I want you to pay attention to is this echogenic line here. You see this echogenic line in the right testes. Now, the right testes is also not normal. And why is it not normal? Because this is the mediastinum testes on the transverse image, and it should be seen in the lateral aspect, the posterolateral aspect of the testicle. Here it is seen in the anteromedial aspect, and this implies that this testicle is not fixed properly and is prone to getting torsed. So that's why when the surgeon would go in to fix the left testicle, they will go and check the right testicle and also do orchiopexy on the right side. And this redundant, boggy appearing excess soft tissue structure in the superior aspect of the testicle is a very helpful sign of a twisted spermatic cord. And basically it's twisted, and below that it's all bunched up. So torsion is basically, it has a bimodal age distribution, infancy and puberty, the majority of them, but you also see between 12 to 25 years of age, and caused by the twist, resulting in venous outflow obstruction followed by thrombosis and subsequent compromise of the arterial inflow, resulting in torsion and ischemia and infarction. The normal testes, just pay attention to the normal testes. Now, these are the transverse images of the right and the left testicle. The mediastinum testes is posterolateral. This is lateral. This is lateral. So the mediastinum testes is posterolateral in location, and it runs craniocaudally, as you see. Sorry, this is the sagittal image. It runs craniocaudally on the sagittal plane and is seen posterolateral in the transverse plane. And the testicle is ovoid in shape. It has this echogenic line, which is the tunica albuginea, and of course the scrotal wall that is also consisting of subcutaneous fat, skin, and the dartos muscle. And the normal spectral waveform is low resistance, high flow pattern in both the testicle and the epididymis. And it's a high resistance, low flow pattern in the scrotal wall because there the supply is coming from the cremasteric artery. Now, I want you to just give a minute to this slide. It's very important, and I hope you all understand the bell clapper anomaly. It is very common and common underlying cause for predisposing risk factor for testicular torsion. The normal investment of the tunica vaginalis, indicated by this red lines, is basically at the superior and inferior end, epididymal head, the tail of the epididymis, and that's where it inserts. But in a bell clapper anomaly, it forms a sac around the distal portion of the spermatic cord, engulfs the entire epididymis and the testicle, such that the testicle and the epididymis and a part of the spermatic cord are lying free within this sac formed by the tunica vaginalis, and predisposing this testicle to undergo torsion in case of any acute insult. And this can be diagnosed, a bell clapper anomaly, if you were to see a small hydrocele. And if you see the hydrocele that is encircling the distal spermatic cord, then you know that this patient has a bell clapper anomaly. Of course, I also talked about the location of the mediastinum testes, the echogenic line. If it is medial in location, you know it's abnormal fixation of the testicle. Also note how when the testicle gets torsed, it becomes more horizontal in position rather than its normal longitudinal position. We'll just skip the clinical findings, but I want you to be aware of the fact that the likelihood of salvage of the testes is related to the time elapsed between the onset of torsion and detorsion. So time is critical, and the salvage rate goes down as the time lapses. And not only the time elapsed, it's also the degree of cord twist. So do not use the time elapsed or the history based on the history as a criteria for claiming that this testicle cannot be salvaged, because if the cord is twisted only less than 360 degrees, then the time elapsed could be longer and the testicle may still be viable. This demonstrates the snail sign and the classic whirlpool sign on Doppler, denoting a spiral twist at the external inguinal ring or in the scrotal sac of a twisted spermatic cord. A companion case where the swelling and pain have been there for 2 days, and you can see the scrotal wall thickening, but you see that the testicle is firstly, this is abnormally oriented. It looks very heterogeneous. It has a horizontal line. Now, this is a transverse image, so you should see just a round circle, but it has a horizontal altered lie, and it's enlarged. It's avascular. So this testicle is has tores and undergone infarction, and a more advanced case of testicular torsion where you see peripheral testicular revascularization from collaterals. And this is a good sign. When you see a heterogeneous testicle, there is a high chance that the testicle is not viable, but it should still be given the test of surgical exploration, as this is not definitive. And so therefore, when you see this sign, it should not change the overall management, but perhaps it can be discussed better with the patient before taking the patient to surgery as to the chances of testicular viability restoration are low in this case, and this is most likely infarcted. Now, this interesting case, which I want you to pay really close attention to, this case has come in to rule out torsion. And you have the right testicle, left testicle. This is a transverse image. So notice that the normal testicle is oriented longitudinally. So if the patient is lying down like this, the testicle is also in the longitudinal orientation. So when you go transversely, you will see a nice circle like you see on the left side. On the right side, it is located, the lie is horizontal. So you're not seeing the nice rounded shape. It's more ovoid and horizontally oriented. Also, look at the vascularity. This is the left testicle, that's normal vascularity. Look at the right testicle. This vascular pattern is different compared to the left testicle. Look at the hydrocele. The scrotal wall is slightly thickened. And if I show you, the left testicle is 23 cc in volume and the right testicle is 32 cc in volume. Any thoughts what this could be? And so here the vascularity is uniformly distributed in the left testicle. And here, if you notice, this portion of the testicle has no vascularity. So this patient, no, it's not detorsed because the vascularity is not increased, but it's a little asymmetric. Yeah, I guess because you think this is slightly increased. But the key here is that when you look at the spermatic cord, it demonstrates a twist, a whirl sign. And that means that this testicle is still torsed. It's partially torsed, and that's why you still have flow. So this patient underwent surgery and was successfully detorsed on the right side. So just keep the entity of partial torsion in mind. This can be quite challenging, and torsion is not an all or none phenomenon. You could look at the resistive index. It could be asymmetric, increased on the side of torsion compared to the other side. The diastolic flow is reduced on the side of partial torsion. You may see diastolic flow below the baseline, or there could be variability in the diastolic flow within the same testicle. So it's just a point to remember that it's not always complete. Torsion could be partial or transient, and arterial flow is not necessarily absent. And that's when you need to pay close attention to all the other parameters. Now, this case is a 15-year-old male with severe acute left scrotal pain, And the pain was started only 20 minutes prior to arrival. And the pain is on the left side. History only 20 minutes prior to arrival. We have the right and the left testicle side to side transverse image. And then I have the Doppler image side to side, right and left. And you notice there is increased vascularity to the left testicle, increased vascularity to the left testicle compared to the right. And this is the epididymis. That's also increased flow. So my question to you is this a case of torsion or epidydmarchitis? Please pay close attention to the history. Pain started only 20 minutes prior to arrival. It's just a trick question. Excellent. Yeah, it is detorsion. It is not epidydmarchitis. History is key, and there are no other signs of, at least clinically, there were no signs of epidydmarchitis. But the critical finding was the emergency room physician had just detorsed prior to the scanning. So the tech placed the probe. This was totally devoid of flow on the left side. The physician detorsed, and the images were taken right after detorsion. So you have reactive hyperemia. So pay attention to all the clinical clues and work very closely with the emergency medicine physicians. Now, this 6-year-old male has right-sided scrotal pain. So I have representative images. You have the testicle, you have the epididymal head here, and you have another structure at the superior pole of the testicle on the right side and near the head of the epididymis. And there is increased flow in the epididymal head. So what is your diagnosis? Epididymitis. Any other thoughts on this case? This is a pediatric patient, right-sided scrotal pain. That's a good thought that this is epididymitis. The flow, this epididymal flow is slightly increased. Yes, Dr. Sarangi, excellent. And this is a case of torsion of the appendage. And the key is identification of this structure, which is adjacent to the epididymal head and abutting the superior pole of the testicle. So this needs medical therapy, not surgical. And this is an avascular structure. It's the most common cause of acute painful scrotum in pediatric age. And you see these appendages, which are remnants of the mesonephric duct, which is the epididymal appendage, or the Mullerian duct, which is the testicular appendage. And the location is classic. If you see a spherical shape, you see increased size of greater than 6 millimeter maximum dimension, no internal vascularity. It could be hyperechoic or hypoechoic. You might see a small reactive hydrocele, scrotal wall thickening, an enlarged and hyperemic epididymal head, which is reactive. You can make the diagnosis of torsion of the appendage. And the management is conservative, and that's a classic blue dot sign that's seen on clinical examination. This interesting case is a 2-year-old with left scrotal swelling. And I have representative images. This is a left scrotal sac. You see a large amount of complex hydrocele. That's the testicle. That's the epididymal head. And that is a large complex cystic structure, which is devoid of any flow. There is slightly increased flow within the epididymal head here. And this is a very interesting case, again, of a large, this is a testicular appendage and appendage epididymis. And it's a cystic appendix epididymis that has undergone torsion. Please note that cystic appendix epididymis is seen frequently in 36% of cases of epididymal appendages. And they can either be pedunculated or sessile. And when they're pedunculated and cystic, they're predisposed to undergoing torsion. So if you see a cystic appearance alone, don't mistake that for a torsed appendage. It's only when you see it in combination with the other findings, like hydrocele, surrounding hyperemia, scrotal wall thickening, and pain, you suggest the diagnosis of torsion. Now, this is a classic case of epididymitis. You can see an enlarged, very heterogeneous appearing epididymis, body, tail, and hyperemic. And this usually it's a retrograde spread of infection from a lower urinary tract infection. So keep in mind that because it's a retrograde spread, so the vas deferens is taking off from the epididymal tail. So often if the epididymal head and body are normal, the tail would be enlarged and infected. So when you're suspecting an epididymitis, don't forget to look at the epididymal tail, and they can be complicated by either abscess, infarction, or a pyocele. They may not be infectious. They could also be chemical-induced, drug-induced, or post-trauma related. This is an interesting another case of epididymoorchitis, which is involving the testicle, also hyperemic, heterogeneous, and the epididymis is enlarged and hyperemic. There is a little bit of scrotal wall thickening. Always pay attention to the spermatic cord, the history. As we all know, that torsion, detorsion can also have a similar appearance. Now, this patient is a 16-year-old male with left-sided scrotal pain. And this is the right testicle, which is normal. You can see the normal right testicle. In the bottom row is the left testicle. And what you're seeing is the subtle hypoechoic ovoid area within the left testicle. And this is showing increased vascularity. So what are your thoughts? Well, in this case, it is either focal orchitis or it could be neoplasm. But the patient, when I called, they said the patient is recovering from a recent viral illness. So it was presumed to represent focal orchitis, and follow-up is extremely important as tumors can look just like this. So focal orchitis can mimic a neoplasm both clinically and on ultrasound. And while history can be helpful, please, when you see a focal lesion in the testicle, always do a follow-up. Now, this patient has scrotal pain, fever, and chills. And history is classic of an infectious process. And you're seeing a scrotal wall thickening, markedly enlarged, heterogeneous epididymis with hyperemia. The testicle is also heterogeneous, enlarged, edematous, and with increased vascularity. And this is a case, and the spermatic cord is also very heterogeneous and hyperemic. This is a case of right epididymoorchitis and funiculitis. So in the ER, we're going to think of the common entities first. And this patient, a day later, a CT was done because patient is bacteremic with MRSA, is an IV drug abuser, has hepatitis C. And you can see these evidence of septic emboli, effusions bilaterally. There are small splenic infarcts, which were new. There is perinephric stranding. I think there was a renal lesion as well. And there is some edema of the scrotal wall. And the scrotal ultrasound was repeated. And this has shown progression to formation of testicular abscess, infarcts. And look at the rapid progression. There is a large biocele now with septations in the fluid in the scrotal sac. This is how soon it can progress. Another very interesting case of a patient with right testicular pain and fever 5 days. And you can see the biocele. It is obvious. You can also see that the right testicle is hyperemic. It is enlarged and hypoechoic compared to the left testicle. But the patient was not doing well despite IV antibiotics. This is on 4th July. 2 days later, a repeat ultrasound is done because patient is complaining of severe pain, is very tender. And what you can see now is diminished flow within the testicle, only see in the periphery. It's very high resistance flow compared to the left testicle, which is a normal low resistance waveform. And it is slightly hypoechoic. Of course, the scrotal wall edema is there bilaterally. And this patient has basically developed severe ischemia and is very painful, underwent a contrast-enhanced study, which demonstrates no flow in the majority of the right testicle, indicating infarction, and had to undergo surgery for testicular compartment syndrome. Pretty much the large portion of the right testicle had to be debrided as it was infarcted and necrotic. So that's a rare condition, but such patients who develop a compartment syndrome usually have extreme pain and tenderness. And this is going to be my last case because I think it's going to be 9 p.m. soon. And this is easy. I already have some responses. I think you've already preempted my last case. This patient with severe scrotal swelling. I have the scout image and you can see some scrotal swelling, immense, and small lucencies in the scrotal sac. And this is a case of Fournier's gangrene. There is swelling, which is quite marked, subcutaneous fluid, air loculi, also in the scrotal sac apart from the wall. And patient had reactive lymphadenopathy, hydrocele. And this was the first presentation of this patient, was not known to have diabetes, but was found to have a blood sugar of 200. Ultrasound of a similar case demonstrating the dirty shadowing from the echogenic foci in the scrotal wall, indicating gas. And another companion case, again, large air fluid collection with diffuse scrotal wall edema, and that's extending into the perineum. A case of Fournier's gangrene, was strep B positive and had leukocytosis, had to undergo surgical drainage, and ultrasound showing the dirty shadowing from the echogenic foci and the scrotal wall. This is a urological emergency. It's life-threatening, fulminant necrotizing fasciitis, and the rate of progress is pretty rapid. So you need to intervene early, immediately with surgical debridement and aggressive antibiotics. It's a clinical diagnosis, and radiology is helpful as you can confirm the diagnosis and also demonstrate the extent of inflammation in terms of depth and overall spread of infection across soft tissue planes, and see if there are any fluid collections. And of course, patients who are diabetics, immunocompromised, or alcohol abusers are predisposed. And this can be fatal, as it can lead to sepsis, multi-organ failure, diabetic ketoacidosis, and renal failure. And so with that, maybe just one last case I'm going to show you of scrotal trauma. This is a 38-year-old who was hit with a cricket bat and is complaining of severe pain in the right hemiscrotum and swelling. So I have images of the right scrotum, and this is the normal left testicle. And you have the Doppler of the right testicle. So you can see there is scrotal wall edema. There is a large amount of fluid in the scrotal sac. And if you follow the testicle, that looks quite irregular. And this is the tunica albuginea, the echogenic line, and you lose that echogenic coating of the testes, the covering, the tunica albuginea, with protrusion of the testicular parenchyma seen very well in this region. These hypoechoic areas in the testicle likely representing hematomas and no vascularity. So compare that with the normal testicle that demonstrates the tunica albuginea very well. A case of testicular rupture defined by disruption of the tunica albuginea with extrusion of testicular, the seminiferous tubules. And basically the tunica vasculosa, which supplies blood to the testicle, is in close apposition to the albuginea, and that gets disrupted and results in testicular infarction. And you need to intervene emergently. If you do so, you can salvage 90% of these cases. But if you leave that, you will probably lose the testicle. And usually they debride the avascular and lacerated portion of the ruptured testes, and the viable portions are left behind. And if there is no or little vascularity, or if it is completely infarcted, then orchiectomy, of course. And this is a case of testicular fracture where the tunica albuginea was intact, but you could see an avascular hypoechoic plane traversing the testicle in a case of blunt trauma. So with that, I am going to end my cases, and maybe I have a few more, which I will cover maybe in a subsequent talk. I'm going to take the questions now. So let's see. Sorry, let me just. So I have a few questions here. Inguinal hernia or ultrasound, please tell anatomy. You know, I think I should show you the images, which I don't have, unfortunately. Maybe this can be taken up later, but the the CT anatomy, I'm sure you're aware of. You have to look at the location going medial, inguinoscrotal, going medial to the pubic tubercle on CT, and of course the inferior, anterior inferior epigastric artery. Those are the landmarks, but ultrasound, I'm sorry, I don't have the images. So the second question is, if mediastinum testes is medial in location, does it mean torsion? No, it does not mean that this is torsion. But if you see the mediastinum testes that is medial in location, it means the testicle is not fixed appropriately. So the fixation is abnormal and it is predisposed to undergoing torsion in case of an acute insult in the future. So that needs to be fixed. Patient will undergo orthopexy for that if it is detected incidentally and you've seen torsion on the other side. So ma'am, please cover some points on testicular Doppler in partial torsion and detorsion. Okay, I think, yeah, let me just go to my slide. That's a good one. So that's, so as I mentioned, you can see partial torsion is a challenge, and you first pay very close attention to the grayscale findings of the testicle. First, look at the location of the mediastinum testes, look at the orientation of the testicle. Like the testicle normally in anatomically is seen in a longitudinal plane, but as I showed to you here in this diagram, let me see. Yeah, so this one, so if you see a sagittal image, it's longitudinally oriented. When you do a transverse image, it's usually rounded in configuration. The mediastinum testes is lateral in location. So if you see in the medial location, let's look at the normal spectral waveform. This is a low resistance, high flow pattern in the testicle. The RI is usually about 0.6. And always compare it with the opposite side. If you see a discrepancy, you need to raise the alert for possible partial torsion in the right clinical setting. So when the testicle is getting torse, see the change in the orientation of the testicle. From a longitudinal orientation, it has undergone torsion and is now oriented in a horizontal plane. So if you were to scan it in the transverse plane, the testes would look oblong rather than rounded in contour. Let's look at the Doppler findings of partial. Okay, so this one is, let me show you. So firstly, some change in the Doppler flow pattern. There is, rather than a uniform, this radial appearing testicular blood flow, you have an area that is devoid of blood flow, little hyperemia, so-called hyperemia in the periphery. Always look for the twisted spermatic cord. That is going to be a very helpful sign, the most helpful sign to make a diagnosis of torsion. And as I mentioned, the resistive index, like for example, this is a side of partial torsion. The flow is there, but the RI is 0.7 and it's 0.65 on the normal side. Look at the diastolic flow. It is reduced compared to the contralateral normal side. So these are the findings that can help you. Basically compare the two sides, and the affected side where the pain is would show increased RI, or might show a diastolic flow that is below the baseline, or a reduced diastolic flow. And the diastolic flow might show some variability within the same testicle. So as I showed you the flow in the testicle on color Doppler, it's not uniform. The diastolic variability may also be there. So these are the subtle signs of partial testicular torsion, but I think the gray signs are very useful. Looking for the whirl sign, the spermatic cord twist is extremely useful. So I think that's all that I have in terms of questions. With that, I think we come to the end of the session. Any other questions are there, Sudarshan, that I have missed?
No, ma'am.
Okay, all right. So I want to thank you all for attending this session, and it was really a pleasure. I enjoyed thoroughly, and thanks for all your enthusiastic responses in the chat box. That was wonderful. I think you're doing great. And I want to thank Dr. Smitha for doing the first talk on gynecological emergencies. And thank you to the ICRI leadership for the opportunity to all of us, and for showcasing the emergency radiology cases, and to Team Vidocto for hosting us and organizing the show. So over to you now, Darshan.
Ma'am, this is tomorrow's flyer.
Okay, so tomorrow is the coverage of interventional radiology, and we have 3 speakers. Ablative techniques, expert session of managing hepatocellular carcinoma, pulmonary vascular interventions, all are great speakers, all accomplished interventional radiologists, as I can see. So do log in. And then we also have this program, Advancements in Breast Imaging. This is for the coming Sunday, 13th of November, 7 p.m. We'll cover all the recent advances in breast imaging, role of AI, contrast enhanced mammography, and breast MRI as a problem-solving tool. Oh, that sounds very exciting. So stay tuned.
Thank you, ma'am.
And thank you.
Ma'am, I'm concluding the session, ma'am.
Yeah, thank you
On
very
behalf of-
much. Bye.
Bye, ma'am. On behalf of the organizers, we thank everyone for being a part of this wonderful webinar. As a part of webinar team, the Sudarshan and Shweta signing off. Wishing everyone a good night. Anjali ma'am, with your permission, may I end the session?
Yes, please. Thank you. Yeah.
Thank you, ma'am.
Bye.